Hello everyone and welcome. I'm Rhonda Ann Gerst, the RHC Program Manager here at the Office of Rural Health. Today's webinar, brought to you by the Oregon Office of Rural Health, is titled RHC Basic Billing and Coding, presented by Charles James from North American Healthcare Management Services. Charles is President and CEO of North American Healthcare Management Services, which was founded in 1992. Charles is the current Vice President of the National Association of Rural Health Clinics and the President-elect for the Illinois Rural Health Association. Charles is a longtime participant on the NARHC Policy Committee and NRHA Annual Policy Institute. He provides educational sessions and webinars on billing and compliance to organizations across the United States. Charles, David James, and Charles James Sr. started North American in 1992. Charles and David have overseen development of all RHC, RCM, and EHR processes for North American. Charles has a Bachelor of Science and an MBA from St. Louis University. As a reminder, on Wednesday, June 17th, from 12 to 1 p.m., Charles will present Advanced Billing and Coding webinar. I have a few housekeeping details. This webinar will be recorded. The webinar and slides will be posted on the Oregon Rural Health website. You are all currently muted. At the end of the webinar, there will be time for Charles to answer your questions. Please type questions into the chat box, or you can raise your hand and Charles will answer your question. After the webinar, I will send out a survey. Please take time to complete the short survey so Office of Rural Health can continue to improve our webinars and bring you the training and education you request. At this time, I would like to present Charles James.
Look at this. Productivity, payment limits, and other factors are considered in the calculation. So productivity limits, we know we've got 4,200 per physician, we've got 2,100 visits for nurse practitioner, that's per FTE, and that is cumulative. So the FTE, if we have 2.8 FTEs, we'd be subject to, I just did the calculation, as a matter of fact, this morning, 5,880. So this is based on FTEs. It is cumulative. It is the denominator of our equation. It's important to measure it correctly. I'm not going to spend a lot of time on rate setting today, but provider-based clinics, part of the hospital cost report, got to allocate RHC space and personnel to get that rate. Got to measure those provider FTEs. Only time spent in the RHC counts for that. Medical director and practitioner FTEs have a major impact, and we have to remember laboratory expenses have to be allocated out. Some of the payment limits we've talked about, independent RHCs, either what we thought of in the old days, seems a little antiquated, as private physician offices or hospital clinics whose parent hospital is greater than 50 beds, are going to be capped at the independent rate, which is the 8631 we referenced. We've got to file cost reports 5 months after the close of our fiscal year for independent RHCs, and failure to file your cost report results in hate mail and no money from Medicare, so make sure you get your cost report filed. Of course, we know the time for that has been extended to July 31st, I believe, but don't wait. Get your cost report in. We do cost reporting, by the way, so some of you may know David, our CFO, who is our chief cost reporting guru. The other the other payment limit is that our cause by default are hospitals with fewer than 50 beds. It's any hospital with fewer than 50 beds, which are available on within 24 hours. It's not licensed beds. It's not anything other than beds available within 24 hours, but you're subject to an uncapped rate, and that's a pretty sweet deal, and that's why many of us are here. We have to remember that our Medicare claims are Medicare Part A. For RHC, what I like to say is that we are Medicare Part A bones with a Medicare Part B skin. This is a really important issue to remember. I a lot of times get questions about, hey, what happens if my patient doesn't have any Medicare B benefits, they only have Medicare A, can they be seen in my rural health clinic? No. A rural health clinic is a Medicare Part B provider, but all of our payment mechanisms are Part A. Part A, skeleton, Part B, skin. So all of our patients' coinsurance and deductible amounts are Part B coinsurance and deductible. If your patient is not Part B eligible, they're self-pay in your rural health clinic. Part B, fee-for-service, CMS 1500. We have many different ways we can say it. Physician fee schedule, Medicare physician fee schedule. Anyone paid on a 1500 is on the Medicare physician fee schedule, and that is not us. And that's why we get left out of a lot of things. That was the problem with all of the telehealth benefits at the beginning of this. It was subject to fee-for-service providers only, and rural health clinics were excluded from the waivers because of that. So we get excluded from things. That's one reason right there, is it's just oversight in many cases. So we're not paid on the physician fee schedule. We have some services that can be. Those are our non-RHC services. We're going to touch on those. That's what I want to spend a little extra time on today. That was a big question, I think. It's important to remember, and this goes into our billing, remember that our RHC, provider-based RHCs, are not departments of our hospital. We are everything but. We are provider-based. We have to be financially, administratively, operationally, and from a marketing perspective, public awareness, we have to be integrated with our main parent, but we're not a department of the hospital, which in 41365 of the Federal Register, the CFR 41365, which is our provider-based payments, the term Department of Provider does not include an RHC or FQHC for the purposes of this section. So that's a big deal because it waives a lot of provisions as far as EMTALA, as far as location requirements, many other things, but and as far as the fees that you can set in your clinic, that's really important relative to the fees you can put on your RHC claims. We are not subject to MIPS, so we don't get the downward or the positive adjustment. Many of us belong to ACOs, so we eliminate that. Again, MIPS and rural health is a totally different presentation that we could spend our whole hour on that. We're not going to go very far into that today, other than to say that we're not subject to MIPS because most of our RHCs these days don't meet the minimum thresholds, and all of our payments are excluded. They're non-physician fee schedule payments, so they're out of the MIPS bucket. So there's a little bit of a primer on where we send our Medicare claims as an RHC. You see that everything over here, ooh, I see my ancillaries chopped up a little funny there, but the biggest differences on our lab tests between the two, are biggest differences between our lab tests for provider-based RHC and our diagnostic testing, and we're definitely going to get to that. Now, let's start building the test for our claims. Here's a trick question I like to ask in person when I do these things. What are we missing from this? Following providers. Yes, it's a trick question. What we're missing is specialty. Notice it doesn't say anything about specialty. Remember back on the total provider hours, it just says 51% of our total provider hours have to be primary care. It doesn't say they have to be rural health clinic services have to be provided by, no, it doesn't say that. It's any physician, MD or DO, any nurse practitioner, any PA, or certified nurse midwives have their own specialty, chiropractors, dentistry, optometrists, podiatrists, bit of a tongue twister, are eligible providers. There are a big asterisk on all of those providers because their services are fairly limited in a rural health clinic just because of Medicare law and a couple things that we're going to find out here shortly. We have eligible behavioral health providers. Our behavioral health providers do not count towards our 51% of provider hours, and as a matter of fact, we have to make sure that we don't have more behavioral health hours than primary care hours because we're statutorily, it means we're by law, we can't be primarily a behavioral health facility. That's been a big deal in trying to get some of this drug addiction treatment and opioid treatment rolled into our rural health clinics, because we can't create an imbalance in our primary care hours with those services right now. So behavioral health, though, is it can be integrated, and we encourage it to be integrated into rural health clinics because those are payable services. All of our rural health clinic claims have to take place at the RHC, at the patient's place of residence, at a Part A covered SNF, or scene of an accident. It's kind of a weird one, but we tried at the beginning of this. We were hoping that the scene of an accident actually says or other locations could apply to our telehealth services, but that was the dead end as well. And of course, right now, the big thing is that our RHC or FQHC, we got the distant site and originating site waived for these visits to take place in. So right now, our telehealth visits would be coded and billed as if they had taken place in the rural health clinic, if that's where the provider is. We can even loosen that a little bit. But hard stop, RHC locations are RHC, patient's home, including assisted living and nursing homes, Part A SNFs, scene of an accident. So now we've got providers, we've got locations, we've got never a location is our hospital, including inpatient or outpatient. We're never going to bill a rural health clinic encounter from our outpatient or inpatient setting. We can bill for our providers in those settings, just not under our rural health clinic provider number. That's the difference. We're talking about is not an RHC location for an RHC encounter. That doesn't mean that our providers can't go there and provide services. And we're going to see that with our non-rural health definitions here momentarily. So what's the $64,000 question is, everybody that starts out with rural health clinic billing, and I have to say, let me take a brief aside here. Here's the problem with basic RHC billing. If you're doing RHC billing, it's already not basic. We're already at least intermediate, if not intermediate advanced in our billing level. So to say basic RHC is a bit of a misnomer. It's a reversal of much of what we know in the fee-for-service world, so it's already pretty complicated. So if you feel like I'm flooding you with information, everybody says that in a basic billing. They're like, oh, this doesn't feel very basic. Well, it's not, is the issue. So back to the question, $64,000 question. All of us, when we're new to rural health, we say, well, where, and I struggled with this too. Way back in '92 when I was trying to get our rural health clinics, and before that, our James Clinic clinics, billing rural health. We said, well, what goes on the claim? And they're just, of course, at the time we had literally 2.5 feet of cost report manuals that they would send to us to sort through, and we didn't have the internet to look at. But here's the answer. This is what goes on the claims. Yes, we have a list of codes. There are qualifying visit codes, but these go on the claims. Your physician services, anything incident 2, nurse practitioner PA services, anything incident 2, clinical psychologist LCSW, anything incident 2, visiting services to the homebound and home health shortage areas. I'll bet you've got some out there in Oregon would be my bet. And all of those now, all of our HPSAs are home health shortage areas. That's one waiver we've got right now. So a nurse visiting a patient's home, that I think we want to send a lot of nurses to patients' home right now, but those are all waived. But these services, in, of course, very general terms, are what go on the claim. Anything our physician, nurse practitioner do, anything that is done on their order, incident 2 for that patient. Here's how we define those incident 2 services. I don't want to go too far down in the weeds on there. Commonly rendered without charge, commonly furnished. Under physician's direct supervision, we're going to talk about that in a second, and it includes all of our drugs and biologicals that are not self-administered, includes all of our nursing services, etc. They're covered and paid. All these incident 2 services are covered in our rural health clinic encounter. They're just not separately payable. We can bundle services that occur generally so in medically reasonable time frame. Medicare doesn't say right now, they don't cite 30 days anymore, but they say medically reasonable time frame. So we can bundle services incident to an encounter 30 days before and after an encounter. For example, our injections that happen by themselves, people's light bulbs are going off on their head. This is how we handle our injections. They don't happen with an encounter. They should be. The only effect on these Incident to services is to increase the charge, and therefore our co-insurance. So when there's no effect on our Medicare reimbursement, but in our total reimbursement, there's absolutely an effect. So if we don't charge our injections out, we're losing 20% of that right off the top. Anytime we say the cost for these services are included in the cost report, that really means those expenses are already built in. There's no magic cost report field to pay me my unpayable line item money. It doesn't work like that. They go in to support your rate. Direct supervision, blah, 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 incident to service, providing somebody under contract. You can go back and look at that. This is when I say direct supervision. So for our incident to services, those are a little squishier now under public health emergency. We can do some things and we can supervise remotely right now. But in general terms, so in normal circumstances, our supervising provider has to be in the clinic. Right now, that's got some flexibility. These are not medically necessary, and therefore they're not really encounters. So injection only, suture removal, dressing change, script change, none of these are encounters, but I suggest that really those are documentation issues. Venipuncture is included in our encounter, even though that's a lab service, really, that's part of our encounter, and Medicare requires us to bundle it into our encounter. Our encounter is, again, in non-public health terms, or non-public health emergency terms, it's a one face-to-face encounter between our patient and physician, and we still rely, we've got some audio-only waivers. There's a face-to-face encounter between one of our providers where one of our RHC or FQHC services are rendered. So remember back here, I'm going to back on that, what goes on the claim listing, those are our RHC services, physician services, anything incident to, practitioner, anything incident to. So that's what all goes on the claim. And then we have our qualifying visit list, which I'm not going to display here, but it's basically all of our list of codes where a provider would put their hands or eyes on a patient. E&M codes, joint injections, minor surgical procedures, I just worked backwards on the list, and our behavioral health services are all on this qualifying visit list. So our codes for our qualifying visits will go on our claim form, as will the incident to detail. We're going to submit our Part A claims on a CMS UB04, which in electronic speak is an ANSI 837 institutional claim. Our original claims are going to be 711 revenue or types of bill, types of bill. We'll cover some other types of bill in advance. We have to use a revenue code. All of our qualifying visits have to be denoted with the CG modifier. We've got to report our incident to services on the claim, but bundled with the qualifying visit. We can use all the revenue codes out there in the universe, except these codes, which are therapy codes. That's loosening up a little bit, but I would suggest to you these are the only revenue codes we're going to need for right now on our RHC claims. You see 521, 522 is the home, 524 is Part A SNF bed, etc. Behavioral health down to 900, and just for the record, that telehealth revenue code is only for the originating site. Don't go billing all your telehealth services that are provider services under 780. Those should be revenue code 521. We're going to charge our Medicare beneficiaries the same amount that we would charge everybody else. Our fees are not going to change. We have to maintain our reasonable and customary fees, but Medicare is going to pay us 80% of our rate plus 20% in co-insurance or whatever the deductible amount might be. So keep in mind there that then Medicare is going to pay us 80% of our rate plus 20% of the charge. It's not one times the rate, and we don't go just charging out our rate. We charge our normal fees. The Medicare payment comes back at 80% of the rate. We got the CG modifier added back in 2016. That seems like another lifetime ago now. And we can also bill preventive services. here's what our line item is going to look like. Established patient, qualifying visit by the nurse practitioner PA. So we just see this pretty straightforward. We've got our CG modifier on here. That's the drill for a claim. Let's look at some incident to detail. So we're going to add Toradol injection. And this is what I mean by bundling the services. And this can be a software function. It could be a manual function. The way everyone does this is dependent on their own system. But we're going to bill our qualifying visit. So the way this gets posted is dependent on your internal workflow. We've got a mix of manual and automated on our part, probably 65% manual, but that erases a lot of headache. So you'll see what I mean here momentarily. So then we just take those additional line items, $20 and $30 for the injection, admin, and medication. We add those to all of us new to rural health. Is that even legal? Yes, this is what's in the Medicare Benefit Policy Manual. And that brings so we still have our $100 charge. We bundle the extra $50, and you see our total charge is overstated. This is a perfectly correct way to do this. The remittance advice will come back with the total charge on it of $200, but the patient co-insurance will be based on the qualifying visit line of $150. Patient co-insurance will be based on $150, and that's how we bill that claim. Now, if we don't like that extra revenue, that $200, the fake $50 in there, remember here we've got $50 extra built in because of these line items right here. I pull out my pointer here, but I'm always afraid that I can't just get my regular stuff back. Oh, see, there you go. I shouldn't have done that. Not sure how to erase it. But anyway, we got an extra $50 in here. We have additional service lines. We call this our alternate billing method. And we can build in a 0.01, 1 penny. As long as we report the detail lines greater than 0, we can build them in like that. We're still basing our co-insurance and deductible line on the QVL, right? So we're just trying to eliminate that artificial revenue inflation. And silly me, I screwed that up. That should be, I need to go back and change that, I'm sorry. That should be $150 on there, on that top line that's circled. So pardon me for doing that. That is wrong. $150 should be the QVL, and then the total charge line would be $150.04. So I'm sorry about that. But I hope we can get the point across that the extra $50 should otherwise have been eliminated by reporting. Neither of these are required. Both of these are perfectly acceptable methods of doing this. So it just depends on your system and what your system is built to do. We can bundle different dates of service. Again, Medicare Benefit Policy Manual says if they're furnished in a medically appropriate time frame, which is generally 30 days, but we're not going to span the admit from and admit through dates on the claim. We're going to report the date of service of an encounter. So let's say a patient has come in for an allergy injection. I keep meaning to build this into 4 units of an allergy injection. But the allergy injection happened last week, and the patient comes in, let's say the allergy injection happened last month. The patient comes in, and we're going to use the date of service on the actual office visit. So here I've got the allergy injection as 4/2. You know what I've never done is tried a different date on the allergy injection. I don't think it would pay, though, because it's got to match the from and through date on the top line of the claim. But effectively, different dates of service we're going to bundle in. This is language directly from the Medicare Benefit Policy Manual, so it's okay to do as long as it's a medically appropriate time frame. Where we have an office visit and a surgical procedure, that is on the same day. That is 1 encounter. On next week, we're going to cover multiple encounters. What happens if I have multiple encounters on the same day? That breaks our brains a little bit in this basic session, so we're going to save that. But an office visit and a surgical procedure, say that joint injection on the same day, that's what that would look like. And just for the record, I've got a $180 joint injection built in on our $100 office visit. So this, I have my total charges correct, and I've defaulted to the alternate payment method on the rest of these slides. So the CG modifier, that's our qualifying visit. You can also submit the 20610 as its own qualifying visit. It is on the qualifying visit list. Global billing can be really confusing. Basically, our surgical procedures furnished in the RHC are encounters. RHC has paid these surgical visits at our all-inclusive rate, but our regular billing, global billing thresholds are not recognized in the RHC. So today is my global billing period. If the patient comes back tomorrow, I can see them again, but the trick is it has to be a medically necessary encounter. So if the patient comes back and they need their wound rechecked, they've had an exacerbation, maybe it's gotten infected, let's say it's a week from the original surgical procedure, you just bill probably a 99212 on that. I'm just checking the wound. A dressing change, remember I said, was not a medically necessary encounter. So just coming in for a dressing change on that wouldn't be a medically necessary encounter, and nor would we expect our physician or nurse practitioner to do a dressing change. Now, if our surgical procedure originated at the hospital where there is a global billing period, for example, we've had a hernia surgery at the hospital, and we're seeing the patient back here in the rural health clinic, that follow-up visit follows that patient. So wherever the service originated is what determines the global billing period. That's very confusing, I know. Where the service originated determines the global billing period. That's the deal. So service originates in the rural health clinic. It's a surgical procedure. Today is my global billing period, but all visits have to be medically necessary. Service at the hospital, the global billing period will apply at the rural health clinic. OB, we bill delivery only. I know that's not a Medicare topic, but we'll bill delivery only for OB so that then all the prenatal and postpartum care are typically rural health encounters. So some of this depends how we do it over on the fee-for-service side at the hospital, right? Minor surgical procedures. I've got a funny little pointer here. I don't know if you can see that or not, but whatever. So again, minor surgical procedures, but those follow-up visits for dressing changes can only be billed if they're medically necessary, and we have a documented reason by the RHC provider. So wound is infected, chief complaint, infected wound. Follow-up for lab test. Nope. Lab test results, no, but why did we have the lab test? Or minor surgical procedures, but those are the things to consider when documenting. So there's a couple billing examples for a procedure or two procedures at the same time. I think that top one will be fairly common. I would think that the lower one would maybe not be, but could happen sometimes. Touch briefly, Medicare Preventive Services. We bill our Medicare Preventive Services. They're subject to professional component, technical component breakdown. We have a Welcome to Medicare annual wellness visits and the balance of preventive screenings that we can have billed as encounters. So we have all of these. Our influenza pneumococcal, we never bill a claim for those. Those do not go on our claims ever. I have a slide in here somewhere on that. And then our chronic care management, virtual communication services, I just built those instances. They're G-codes. They're technically preventive services. So we have a different method to bill all of these different preventive services. The Welcome to Medicare visit we can have as a same-day bill. That means if I have an office visit and a Welcome to Medicare visit on the same day, I get 2 encounters. That's the only preventive service like that. All of the rest of our preventive service, there's how to bill that. We don't have to have a CG modifier on the Welcome to Medicare visit. That's the only service like that, I would recommend just putting it on there out of muscle memory. So that's how we bill the office visit. We could put 2 CG modifiers on there as well if we have Welcome to Medicare and the office visit. We can do that. The rest of our annual wellness visits, subsequent annual wellness visit, obesity, education, screening, tobacco cessation, all those preventive service screenings are standalone encounters, so that if they happen by themselves, we have an encounter, they're standalone. If they happen with another wellness visit or another encounter, we don't have anything to bill. So why would we bill it? For all of our quality measures. So we want to track these for our quality measures, so we want to have them on the claim. Our beneficiary coinsurance and deductible are waived, just like the rest of the world. And I've got some more. I definitely have more claim examples in our advanced billing that we're going to do next week. I want to be sure and hit on this non-RHC services. I'm actually fairly on schedule on a whole lot of slides. I'm sorry if, I hope I'm not going too quickly on some of these things, but it's just, we can't eliminate a lot of these things because they're all important issues, right? So we gotta get through them. So let's talk about our non-rural health clinic services. We've got rural health services, non-rural health clinic services. Right in the Medicare Benefit Policy Manual, this is another place where it says we must be primarily engaged in primary care services, but we also furnish services beyond the scope of what we're paid for in the RHC encounter. If Medicare, if those services are authorized, i.e. if there's a valid way to bill those in Medicare Part A, Part B, we must look at the language. The services must be billed separately, not by the RHC or FQHC. Here's what that means. When we hear not by the RHC or FQHC, it means not under that provider number, but under the appropriate provider number for that service. So, i.e. to our Medicare Part B MAC physician fee schedule 1500 would be the appropriate way to bill the majority of these non-RHC services. So we have built into the statute, so built into the rural health clinic law, an ability to bill some of these services fee for service outside of our rural health clinic benefit. Now remember, all the way back on our what goes on the claim, what are RHC services? Our Incident 2 services, those included our drugs and biologicals. They did not include any lab services. Our lab and diagnostic testing, et cetera, are explicitly carved out. So look at our bottom line here. We've got to identify and remove the allowable costs of these non-rural health clinic services such as space, equipment, supplies, overhead, and most importantly, personnel. So we've got to carve non-rural health clinics out. What that means is that those expenses don't go into our rate. We've got to bill those separately to the appropriate A or B MAC. Lab services are not within the scope of our RHC or FQHC benefit. So we carve those out and we bill them fee for service. So here are the services that we bill non-rural health. Anything that's not a Medicare covered service. So cosmetic, Botox, routine, routine foot, anything Medicare excluded. Where an excellent place to find Medicare excluded services is Medicare Benefit Policy Manual. Chapter 15 talks about a lot of these services and how they may or may not be billed. But notice here we've got anything that's not Medicare approved, technical components, lab services, DME. Under normal circumstances, we have telehealth distant site services, but that's waived for right now. Group services are generally not Medicare claims, et cetera, et cetera. So all of these we bill. So DME, we have to go get our own provider number to be a DME supplier. That's not part of our rural health clinic benefit, and we can't roll it in. We can't bundle our lab services, our testing, into a rural health clinic visit. That would really be breaking the rural health clinic law. So these are what we exclude. Diagnostic tests, X-ray, EKG, etc. Those are the technical components. All of our lab services except venipuncture and anything rendered really at the hospital. So our technical components for our lab, the technical components of the lab are non-rural health clinic services. These are going to be billed fee for service, but we have a big difference between our independent and our provider base on this. This is the biggest difference. CAUS get cost-based reimbursement. Independents and PPS hospitals are paid on the fee schedule. Same for, what did I just talk about? Oh, we just talked about technical components lab. For independent, we're going to bill these diagnostic tests to Medicare Part B on the fee, or Medicare Part B provider number. I say carrier, it should be the MAC. Fee for service, $1,500. On provider-based, these have to go and be billed under the hospital. These get billed under the hospital provider number, but with the RHC NPI for the site of service. It's going to confuse a lot of people. This is a big deal. It's a big curveball for everybody, because how do we get these on the hospital system for our rural health clinic? And yes, that's something you've got to work out. But our technical components for X-ray, EKG, ultrasound, and our lab are billed to the hospital MAC using the hospital CCN number, same with the lab. So here are the types of the bill for a CAU and the revenue codes for a critical access hospital, for lab, radiology technical components, EKG technical components. Here's PPS hospital. Same breakdown. Remember, parent hospitals, Medicare number. This is a small PPS hospital. This is a CAU. Biggest difference between provider-based and independent, just in straight billing, right here. Our professional components get bundled into our office visit. Think of those professional services. And here I use just a regular billing method. I've got a $30 professional component bundled into our $100 99213. Our total charge is misstated, but our patient coinsurance on this would be, anybody? Bueller? $26, right? So it would be 20% of the qualifying visit line. Some of us wanted to do 20% of the total charge. Nope, 20% of the qualifying visit line. Hospital services will never have an RHC encounter. This get billed to the Medicare. I swear I thought I'd replaced carrier everywhere. Medicare MAC, fee for service reimbursement. Critical access hospital option 2, it still is under the parent hospital. Visiting specialists. Any qualified provider can see patients in the RHC. Any qualified provider. So our cardiologists, our general surgeons, our ENTs, those are all great fits for our rural health clinic. We have to maintain 51% of our total clinic hours, total provider hours. Write that part down. It's primary care is 51% of total provider hours have to be family practice, internal medicine, Peds or OB. But specialists can absolutely be integrated into the RHC. And we'd have to look at their commercial and Medicaid enrollment, but any qualified provider today can come to your RHC and start billing a Medicare visit. There's no additional enrollment. There's additional commercial and Medicaid enrollment, but any provider can come in and start seeing patients. Now, I threw in this, so there's a behavioral health service that I put on there. Those are our behavioral health qualified visits right there. Very important component of our rural health clinics these days. Many of us are integrating behavioral health services. This is the one instance we're going to see on a behavioral health visit. The welcome to Medicare and the sick visit and behavioral health visit on the same day are the only 2 times we'll have CG modifiers on 2 lines. And notice the CG modifier there and then the patient's going to have 2 encounters and 2 copays on that. Real quick, distance site services. For telehealth, we had that established finally on April 30 for us. We finally got our revised SE 20016. So for right now, we have this new G2025 code that we're going to use for our telehealth visits with our CG modifier. Right now, we're going to be paid our rate for those. Our telephone-only visits can be included in 2025 as long as they're longer than 5 minutes. This includes our portal visits. Excuse me, telephone-only visits. Telephone-only visits, don't quote me on that. Telephone-only. Portal visits are virtual check-ins. So that's what our telehealth distance site service. So right now we can do this. We can have our provider at the RHC and the patient at home, and they're going to bill. We're going to bill a G2025. In our view, if you want to maintain, so we would code in our system the actual office visit that occurred, maybe a 203, maybe a 212. But if we really want to bill those, we would suppress the claim and not have it not go outbound with the G2025. And remember, this billing procedure is going to change on July 1. We'll talk in more depth about that on our advanced session, but I knew there was going to be a big question, so I at least wanted to put this billing example up for right now. Let's go back to January 27, but really most of these are going to be after March, and then our home sites, the patient at home really is for after March 16. Don't go down those dates. That's a big rabbit hole. But if they're COVID related, we can go ahead and put CS modifier on those claims. And if it's COVID related, we have to waive the co-insurance for COVID related testing. So if we put CS modifier on there, the claims will still be paid with the co-insurance, but we just have to not collect it. So how's that for an administrative nightmare? A lot of us are just going to hold claims until July 1, and we've had some MACs tell us we can do that. Wanted to touch on this virtual communication. Remember, virtual communication is not an encounter. So back on the G2025, if telephone visits are included now, what are virtual check-ins? Well, virtual check-ins can be text or portal visits or emails. We bill these, including our telehealth visits, under Revenue Code 521. Our established patients only for all telehealth services waived right now, so we can offer this to all patients, including new patients, effective 3/17. We still can't provide an E&M service within 7 days. It can't have resulted from an E&M within the previous 7 days, and we can't have a visit within 24 hours. So if you'd have had a less than 5-minute telephone visit, I don't know how that would go down with a provider, but that may be just a script refill. Less than 5 minutes, but with the provider, that would be a virtual check-in. Provider gets a text, that works. Emails work. Look at what do we not have on here? We don't have a CG modifier. We don't have a 95 modifier. It could certainly be a CS modifier, but we bill G2010 or 2012, excuse me. We have, again, an RHC FQHC specific code. This code does not include remote monitoring. It includes remote check-in and remote evaluation. General breakdown on our Medicare Advantage plans. How's that for a big, awkward segue? Medicare Advantage is really considered commercial for us. So while they go into the visit count, we may or may not be paid. It's not a Medicare patient. Some of our Medicare Advantage plans will pay your RHC encounter, others will not. So generally speaking, if that Medicare Advantage plan pays you on pays your encounter rate, they're going to generally follow Rural Health Clinic billing rules. if they don't pay you your encounter, they pay you on the fee schedule, they're going to pay, they're going to follow fee for service, normal world billing rules. And one thing I didn't add, I think I must have in our preventive, I always struggle with where to do the preventive services. Do it in basic or do it in advanced. One thing I meant to add in here and did not is that our pneumo and flu shots never get billed to Medicare patients. Those always go on our cost report, always, 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 for straight Medicare, but we would never put our flu and pneumo shots for Medicare Advantage patients, even if they're paying you the rate. Medicare Advantage flu and pneumo never go on the cost report. It's only straight Medicare. I've included a lot of resources in here. So particularly, I want to point out that Chapter 15, Other Services, when you're struggling with how Medicare covers podiatry or chiropractic or optometry, for example, so how we could offer that in our rural health clinic, Chapter 15 is the place to go for those. Virtual communication FAQ, if you're looking for anything related to survey, go to that State Operations Manual, Appendix G. Our provider-based rules are at 41365. Duplicate on that. A couple good reference charts there. I just put the links in here. And then there's my contact information. So, so that's what we had. I made it through 86 slides in that amount of time. So I hope it wasn't too fast for folks. So if you want to go ahead and raise your hand with any questions or type something in the chat box, I'd be happy to address any of those right now. So while somebody's debating on whether or not they want to ask their question, I don't see any right now. You just make a note about telehealth visits. Remember, our ability to bill as distant site is only during the public health emergency. We do not know when the public health emergency is going to end. Of course, many of us hoped it would end by now or by September. The folks that I talk to, I don't want to put any names on it, expect it to last through the end of the year. So what that affects many things. It affects all the blanket waivers for locations and staffing that are out there. But the big thing for us as rural health clinic billers is we can only bill, as the law stands right now, distant site telehealth services through the termination of the public health emergency. So if they came out tomorrow and said it was over, we're back to no telehealth other than being originating site. So what I would ask everyone, including the folks listening in from the Office of Rural Health, is we really need to lobby anybody that will listen, but especially our U.S. senators and U.S. representatives, to support. I'll put a slide up on my next presentation, or have Rondi Ann send something out if she's curious. There's a House bill right now that would get us distant site at our all-inclusive rate made permanent. There's resistance to doing that, but that needs to be our new normal. So please, let's think about what we're going to look like after this emergency is over. So one question came up, can I please explain how to bill group behavioral health in more detail? Well, right now, group visits at the Medicare level aren't allowed. Those are, we've got some confusion because on telehealth, those group codes are payable, but in a regular rural health clinic and regular anything Medicare, to my knowledge, group visits are excluded. Now, you may have at the Medicaid level, I think you do in Oregon, a group benefit under behavioral health. So any group benefits are, generally speaking, not going to be for Medicare patients. because we cannot bill group behavioral health. I'd love to be corrected on that, and there is cross-wiring, kind of contamination, if you will, between the telehealth codes that are allowable and that group services as it relates to rural health clinics, and that's directly in the Medicare benefit policy manual. But let's check our Medicaid benefit for that too. And I think there is some commercial availability for that. Well, excellent. Well, I don't see any other questions populating out there. I'd like to say, and I don't want to speak for Rhonda Ann, but I'm sure that any questions that you come up with staring at your bedroom ceiling at 2 a.m. that you would like to email, please feel free to reach out to me via email. I'd be happy to answer any questions, and of course we'll go into a lot of these topics in more depth next week. So, Rhonda Ann, I think I hit the time limit just right. So
okay, that's perfect. Thank you, Charles. And I will be posting this recording and slides on the Office of Rural Health website. And I also will be sending out a survey after the webinar, so please complete that. And I appreciate all this information for us, Charles. Thank you.
It's my pleasure. Thanks for having me.
Okay, we'll do it again in a couple weeks.
Thanks. Look forward to it. Bye-bye.
Okay, goodbye.